Happy New Year, and I appreciate all of you participating in the first month session of our Opioid Response webinar series. We will be with you throughout the year, the first Friday of every month, and from hours from 11:30 a.m. to 12:30 p.m. There's never any cost. We record all the sessions and try to have a program for you with an interesting topic each month. We've got over 300 people registered today for the session, which is a great start to the year. In a moment, I'll also tell you the programs that we have planned for February, March, April, and May. And we'll send those out at least approximately 3 weeks to a month in advance for you to register. Really want to thank Lorena Liberty at AdCare and Madison Barassa from the Office of Behavioral Health, our program, one of our SUD program managers there, who works very closely with me. We literally couldn't do these programs without AdCare and Madison and the team behind it. Today, as you know, we're talking about the 1,000 Lives campaign. I'm going to tee that up, and then we have really two fantastic physician leaders from Maine to give us more details. Elizabeth Fowley-Mock, who will present first, and then Dr. Erik Steele from Martins Point, who really developed this idea. It's really the brainchild of Dr. Steele, and he'll be joining us roughly at noontime. I don't think there's really any other information I need to give you this morning. I'm going to tell you the program, the topics we have for the next 4 months. I'm going to talk a little bit about our November monthly overdose report, because after all, it dovetails right into the 1,000 Lives campaign, which is intended to save 1,000 Maine lives through preventing fatal overdoses over the next 5 years. In February, we're going to have a presentation on the Maine Prevention from the Maine Prevention Network at the Maine CDC. Those are our primary prevention partners that exist in all of our 9 public health districts, and we'll get a summary of their work. In March, we're going to have the Harm Reduction Collaborative. Have I said that right, Madison? Maybe it's like
Harm Reduction Learning Collaborative.
Learning Collaborative. We also have other learning community, SUD learning community. So the Learning Collaborative, and they will be giving us their summary of their work. In April, the CCBHC, let's see if I get this right, Certified Community Behavioral Health Centers. And that's a Maine Care initiative. As you know, it is a game changer, and we will be getting an update from them in April. And then in May, we have a presentation from the Department of Labor, David Delaney and their group on their QUEST program, which is about employing individuals with a substance use disorder, very similar to our recovery-friendly workplace initiative that was presented as a webinar last fall. With respect to our where we at least ended up in November, the favorable trend of seeing less mortality continued to exist. As the November report was put on the data hub at mainedrugdata.org earlier last week. I've got some notes here on it. In November, for instance, there were 559 overdoses. There were 47 fatalities compared to 66 fatalities a year ago for the same time period, which was 13.6% lower than November of 2022. So as we also had a decrease in both the fatal and the non-fatal overdoses, although in the total overdoses, the decrease year to date has only been 4.4%, and it's been about 15% with respect to the fatal overdoses. We hope that will continue through December. We wouldn't be normally posting the year-end numbers until February 1st. Governor may choose to talk about this and some of our other initiatives in our State of the State speech on January 30th, which would just be 2 days before we normally be posting the December report. We're very careful about how we message, our improvement in mortality, because we're still losing too many people. We all understand that. We'll probably end up the year somewhere around 600 deaths, and that's way too many. It's 600 families that have been impacted, but it is better than 7. And so more to come on that, more specifics, but I also want to acknowledge that the favorable experience to date has not been uniform across the state, that there are at least 4 counties that continue an experience on mortality that is not improved from last year through November. And that would be Androscoggin, Kennebec, Washington, and Piscataqua. Again, this is not to point the finger at them. It's to simply acknowledge that we have a lot more work to do, and we have a lot of things that are now happening, a lot of things we're putting in place, many things that we'll talk about later today that are intended to improve on those numbers. So again, watch for our announcements at the end of the month of the governor's State of the State. And that will give you more specifics by county, by age. There's a lot of data that we collect every week and put them into the monthly reports. The 1,000 Lives campaign, as again the brainchild of Dr. Steele, is also intended directly to lower the mortality with respect to overdoses. It is based loosely upon the 100,000 Lives campaign, which was the brainchild of Dr. Don Berwick, well-known pediatrician who founded the Institute for Healthcare Improvement. The IHI and Dr. Berwick announced just about 20 years ago that they would launch a campaign to try to save 100,000 lives in America's hospitals by implementing a series of actions that, if implemented on a uniform basis, each time a patient arrived, that lives would be saved. 8,000 hospitals signed on to that campaign, and hundreds of thousands of lives have been saved as a result. Dr. Steele's idea of using that as a model to save lives in Maine has been well received. It was announced at the Governor's Summit in July. It was launched on January 1st, but again was announced and we had a media event in Portland the day of the storm, December 18th. There was a lot of media present, and some good publicity came from that, some good interviews with Dr. Steele about what this was all about. Before turning you over to Dr. Ballymock and Dr. Steele, I want to mention just a couple things at a high level. You don't save 1,000 lives over 5 years by simply saying you're going to do it. It actually requires you to do things differently than we've done in the past. That's number one. Number two, this is not a state initiative. This is an initiative of the medical community and the professional medical and hospital systems and organizations, led by the Maine Medical Association, but also joined by the Maine Osteopathic Association, the Maine Hospital Association, the Primary Care Association, Northern Light, Maine Health, the Maine Association of Physician Assistants, the Maine Academy of Family Physicians, the Maine Chapter of the American College of Emergency Physicians, the Maine Association of Psychiatric Physicians. And that is a partial listing, and I apologize for organizations that, in the interest of time, I'm not going to list. And those organizations, that list of organizations participating in this campaign grows every week. So the heavy lifting here in terms of, okay, what specific things is the medical care community going to do differently that's going to bring about the prospect of, based upon previous evidence, of saving Maine lives over these 5 years, which would result in about a 20 to 30% reduction in mortality. What does this look like, and how is it going to be achieved? Those specifics are going to be presented to you by Dr. Mark and Dr. Steele. So I think I've said enough. We may have time after their presentations to, in fact, answer questions. And as those regular attendees of these webinars know, we record all these sessions, and we also answer all your questions in writing if we don't get to them during the webinar itself. Dr. Mark I have worked with for approximately 13 to 15 years. So well before I took this position with the state. She received her medical degree from Vanderbilt Medical School and has a master's in public health and health policy and administration from the University of North Carolina, Chapel Hill. She also attended Colby College and Emory University. She's board certified in family medicine and addiction medicine. Her work really focuses now on clinical education and public health aspects of the overdose crisis. She's been one of our primary academic detailers and one of our primary educators in all things opioid over the past few years, working very closely with Dr. Letourneau and myself. But she also practices medicine. She does the per diem shifts as a hospitalist, so she stays very close to the clinical side. She's been an active member in our clinical advisory committee. She lives in Bangor with her husband and now 3 dogs, now that her 3 adult children have launched successfully out of the home and been replaced by the 3 Labradoodles or something like that. So that's what you need to know about her. She's a great fan of the University of Maine women's basketball team, and we're lucky to have her in Maine. And she's going to tell you, her thoughts about this campaign. And then when Dr. Steele joins us, I'll give him an introduction at that time. So I am turning it over to you, Elizabeth, and thanks so much for being a part of this and for joining us this morning.
Thank you so much. And a quick plug, there will be home games for the University of Maine hockey team tonight and tomorrow night. They might not be sold out because the students are all at home. And against the #1 team in the league, Maine women's basketball tomorrow afternoon at 1 o'clock in Orono. So thank you for the opportunity to talk to you today, to talk to our wider community here in Maine about the overdose crisis, the opioid epidemic. The name has evolved. And I was fortunate to be able to be present at the press conference and represent my specialty society. So I was fortunate, I represent the state of Maine to the national group that talks about policy for the American Academy of Family Physicians. And so at that press conference, I recognized that many family physicians, many primary care providers, many people who are in specialty medicine are already very involved in working with pain and addiction and social determinants of health. And we applaud everyone who is already doing that work sometimes in amazing circumstances, like my colleague and friend Amy West, who is a nurse practitioner in Bangor, who on Friday afternoons gets her backpack and goes out to the tent village behind the Hope House and does wound care on the streets in the field. And we need more people like that to meet people where they are, to extend a hand and not leave them there, but bring them to a place where they have resources and they have opportunities to choose to use safer or to choose to enter recovery. And that's part of what 1,000 Lives is all about, is introducing the medical community to people who are doing this work and to bring all of us along. We certainly don't do that in a vacuum. We in the medical community know we need to act, and there's things within our own house. We talk about the house of medicine. There are things that we need to do and things that we need to do better. And this is in conjunction with a broad panel of stakeholders. Gordon mentioned the state and the governor's opioid strategic plan, and there are so many groups in there. But I specifically want to mention people who use drugs, people who are in recovery, people who are affected others, people who are working in harm reduction programs. These are the bigger circles of groups who are doing amazing work in the state of Maine, and all of us need to work in conjunction and together and to learn from each other. So while this is focused specifically on actions that the medical community can do, that primary care offices, that hospitals, that physicians themselves, that nurse practitioners and physician assistants can take, we recognize that there is a whole lot of effort. And we also need to be really careful that we're listening to the voices, nothing about us without us. Listening to the voices of the people that we're working with and people that we're hoping to serve, and making sure that the things that we are able to do on the medical side of things matches up with things that are happening in the community and that are helpful to people. So all of that in context, I'm really grateful to be able to tell you just a tiny bit about my personal story about how I became interested in addiction medicine. And then Dr. Steele will talk about the campaign itself and the nuts and bolts and the genesis of it. And so I have the lucky opportunity to tell you just a little bit of a narrative of the why of 1,000 Lives. Why does the House of Medicine collectively need to up our game? The initial term for this campaign was going to be Step It Up. And we moved that further to talk about 1,000 Lives, but how all of us can do more, how we can talk differently, how we can change our ways of thinking, and how we can change the ways that we practice medicine to be safer for people and to try to avoid harm. So what led to my interest in addiction medicine? I started working on a chronic pain quality improvement project 10 years ago. And I was a bit naive in terms of understanding the intersection between psychological trauma, adverse childhood events, chronic pain, and addiction, because a lot of those things operate on a spectrum. And I entered that project thinking, I don't really want to do this project, but if I don't engage in this project, the next project might not be offered to me, so I'd better engage. And maybe the next thing will come along and it will be a topic of medicine that I can really get excited about. Well, little did I know that this would then become the area of medicine that I became excited about. So as I learned about chronic pain, and I learned about quality improvement, and I learned about everything that happened with the pharmaceutical companies leading people to be on high-dose chronic pain medications, and then all of the factors that influenced that in terms of then the availability of opioids on the street and the overdose crisis. As I learned that, I realized that there were things that I could do as a physician that would further the efforts. One of the things I learned about in one of the books I read, and usually if Gordon Smith recommends a book, then I put it on my Audible list and I make sure I read it, whether it's Dope Sick or Drug Dealer or all the books by Sam Quinones. I make sure that I read them because they really give me a breadth of information about overdose, addiction, and drug use. One thing I learned in one of those books was about nature, nurture, and neighborhood. And that third one I hadn't heard about. So nature is what we talk about in terms of genetic predisposition, genetic risk, how things can run in families, and how sometimes when people get exposed to something, it's like a switch turns on in their brain. And so that's the genetic predisposition. It doesn't determine 100%, but it determines some. And we know that it's a physiologic process and a biologic process that creates this chronic disease that is addiction or substance use disorders. Then we have nurture, and that's what I talked about in terms of adverse childhood events. So when a lot of bad things happen to us as young children, it predisposes us for having health problems, both psychological and more chronic disease medical, for our entire lives. People who have high ACE scores or adverse childhood event scores have higher incidences of chronic pain, higher incidences of addiction, but also of cancer and chronic disease and cardiac disease. So things that happen to us as children set the stage for as we proceed through life. And so when we talk about prevention and we talk about going back to early stages, we think about that too. And we always talk about prevention, treatment, and recovery, and these are so intertwined. And then we talk about neighborhood. So what's around people? What kinds of family systems are people in? What kinds of communities are there? And in prior episodes of this webinar, we've talked about recovery-friendly workplaces, recovery housing. We've talked about all different types of prevention and things that we can do with our young people. And so all of that is important because where you are and what you have access to and what you see as a young person also determines your trajectory. And to me, it's really heartbreaking to have a patient sitting with me in the office and to be talking about their opioid use disorder and how we're going to treat that with medication, and to learn that the first time that they used drugs was when they were 11 years old with their parent. That breaks my heart because that 11-year-old child was set on a course that was really difficult for them to alter. And so that's just some of the things I think about when I think about why does the medical community need to do more? Because we're maybe not aware of some of these things, and we have some beliefs in the back of our mind about diseases and choices and treatment and medications and what needs to go where. And so I'm really happy to be talking about this as a medical community and seeing what we can do to add to the amazing efforts that are already happening. There are a couple of things that we know about, specifically prescription opioids. And so I focus a lot of my time on the prescription of controlled substances and controlled substance stewardship. We know that people who are on high dose opioids for long periods of time, both of those are risk factors for developing an opioid use disorder. The height of the dose and the length of the time. And so we have to be careful knowing what the science says about the treatment of chronic pain, that in many, if not most situations, that chronic opioids, especially at high doses, are not benefiting patients. And how do we have those discussions? But also for those patients who have developed an opioid use disorder, to recognize that and to treat it. And then for people in other cases, people who've been exposed to prescription opioids frequently as their first exposure to opioids, to think about minimizing that risk and to think about not prescribing opioids, which in fact we have evidence to show are not the most effective treatment for some kinds of acute, even post-operative pain, even wisdom tooth extraction pain, but not prescribing those opioids to that 15 or 16 or 17-year-old. So that really plastic brain isn't exposed to that opioid for the first time. So things that we can do to prevent harm as physicians, as physician assistants, as nurse practitioners, as pharmacists, there's a whole host of them. I'll tell you a couple of anecdotes here, and then if Dr. Steele is a little delayed, I have a whole list of things that you can do. One of the really touching moments for me, I was teaching about opioid use disorder to prescribers and their teams. I went to a practice in Washington County, and I vividly remember it. They wanted the whole practice to come to learn about opioid use disorder. This was in 2018. So they closed for lunch and they actually locked the door. And I remember because I was looking out towards the door and all of the staff was in the waiting room because that was the only place in the office they could fit. And a couple patients tried to come in for their appointment at 12:45 and the door was locked, and they went back and sat in their cars and waited. And we sat there and the office bought pizza and I talked about opioid use disorder. It's so vivid in my mind. And at the end, I finished and I was packing up the PowerPoint projector and I was putting all my stuff away and getting ready to drive from Washington County back to Penobscot County. And a woman who was a medical assistant came up to me and she said, I really appreciate that you talked about this, that you were a doctor who talked about opioid use disorder as a chronic disease and about harm reduction and about medications we can use to try to help people on their recovery journey. My son died from an opioid overdose, and sometimes I can't even talk about it at work. And that touched me so much to know that these people are our children, and these people are our community. And there's probably not many families in the entire state of Maine or even in the country that doesn't have some connection with addiction. And so it's such a widespread problem that we don't talk about as a chronic biological disease. And then the treatments that we can offer people in terms of medications that are life-saving. So I wanted to talk 3 things about treatments. The first thing is the prescription that I write for buprenorphine is safer than the prescription that I'm writing for many other medications. And so that's a reassuring thing that I try to teach to other prescribers, that buprenorphine is a Schedule III opioid. It has a ceiling effect because it's a partial agonist, and it's safer than many of the prescriptions that I've been writing for 25 years. And so we have lots of resources for people who are prescribers to learn about prescribing buprenorphine and how to prescribe it. So that's the first point. The second point is that buprenorphine, and most people know it by the brand name Suboxone, but I have to talk in generics, right? So buprenorphine is one of the few prescriptions that I can write today that will save my patient's life tomorrow. There are very few other prescriptions in medicine that have that immediate of an impact and an effect. Prevention is wonderful and I'm all for that. But if I can save someone's life today or tomorrow, I give them a chance to continue on their journey. So that's the other thing that I think when I write a prescription for buprenorphine. And then the last thing I think about is, now, like, I don't talk about brand names. We all need to be working in harm reduction, because where people are right now, whether they're on prescription opioids or they're using opioids from multiple other very dangerous sources, we need to be talking about opioid reversal agents. And we need to be talking about how do we use these medications and where should they be and who should know how to use them. So that's a conversation that we have very widespread. We're lucky in Maine to have the Maine Naloxone Distribution Initiative. We're lucky to have really robust harm reduction programs. And there's a lot of work in terms of going on of teaching everybody about how these should be in every public place. This is a sample trainer, should be in every public place, just like a fire extinguisher or an automatic defibrillator. So let's see a couple more patient stories until I said I'm kind of like the warm up for the main event here, the main concert speaker. Just a couple more stories that I can tell you about patients that I've worked with, which have made my journey in working in addiction medicine so fulfilling. I took care of a patient in the hospital once, and I work evening shifts at the hospital, which is an interesting place to be. And it's the second largest hospital in Maine, so there's a lot going on. And we had a patient that the nursing staff was having a lot of difficulty interacting with. And they called me and they called me again. And usually by the time they call you the second or third time, even though you're covering 200 patients, you just have to go there and talk to the nurses and the patient and try to work things out. So I talked to the patient, and she had an opioid use disorder, and she'd had surgery for an epidural abscess. And she was getting pain medicine, but it wasn't treating her withdrawal from what she had been using previously. So we talked a little bit, and I said, what do you think about getting on buprenorphine or Suboxone? And she said, I was on Suboxone when I was pregnant a couple years ago, and it was the first time in my life that I felt normal. And I loved that she said that because I knew that she knew that that helped fix that problem in her brain, and that she would be very receptive to talking more about entering recovery. So she thought about it a couple of days. And then after 2 or 3 days, we were able to figure out a way to get her started back on treatment. And now in our hospital, we actually have a protocol that we can get people onto buprenorphine safely, even when they're in the hospital and receiving pain medications. We've learned so much in the past couple of years. Let's see. Oh, I'll tell you one more story that to me is a really heartwarming story. I worked at the Bridge Clinic at a federally qualified health center. And again, with an amazing team of people who were working in low barrier medications for opioid use disorder. We went through a very long administrative process to learn how to do injectable buprenorphine. So this is a shot people can get in their stomach, and it lasts for the whole month. And it's a pretty amazing medication. Unfortunately, it's really expensive, and there's a lot of rules about using it. So it's not available to everyone across the board yet, but maybe someday it will be more available. But for the people who are very high risk, and for certain people that it's the right medication match, it's a really good treatment. So I was learning how to administer this medication. There's a particular way to inject it. And here, a little secret, doctors don't do injections that often, and we don't draw blood that often. Usually we have staff that work with us that do that. And so we're not always the most experienced. So I was learning how to give the injection for the injectable buprenorphine, and the patient was there, and it was a young woman who had really been struggling. And we didn't have visitors come back in the clinic because we wanted to have a private conversation with our patients. But that day we let the patient's mom come back with her, and her mom sat next to her and was kind of holding her hand, because the injection can be really uncomfortable. It's a really thick medication and it goes in your belly. So I learned how to give the injection by working with the other members of my team who'd done it before. And I thought, after the patient got the injection and she was leaving with her mom, what a relief to that mom, because the chance of her daughter dying in the next month was pretty close to zero. And again, I thought that was amazing. So I generally try not to break down in tears while I'm with my patients, but when I tell their stories, it really touches my heart. And I thought, as a mom myself, if I knew that there was some way I could keep my daughter safe, then that would be really valuable to me. So we have these new treatments. We have so much more knowledge about treating addiction than we did in the past, that it's really wonderful. So I see Gordon came back on. Has Erik been able to join us to talk more about 1,000 Lives?
I've not seen him come on, but I was going to comment on a couple of things in the chat, Elizabeth, and thanks so much for your heartfelt presentation. You never need to apologize for breaking down. I do it on a regular basis. We never want to forget the humanity that we deal with, and you've done a great job to make this real for people. There is a note in the chat that I wanted to call to your attention, because there is a new ECHO program starting on January 12th through MCD, and I think Dr. Vincel's part of the faculty for that. I recently saw a note on it, and there's a link to that programming for those practitioners and administrators who would like to, as it says in the note, deepen their skills for interactions with patients undergoing medication. Elizabeth has brought to our attention too there's not only stigma obviously associated with the illness, but there's a lot of stigma associated with the medication, and that's equally troubling when there's many people today who are doing well on buprenorphine or on methadone or on Sublocade, And that's this is an important part of their recovery, and we need to lower the stigma associated with the use of those medications. You want to comment on that, Elizabeth?
Well, I can talk a few things about action steps. The first thing is to address our stigma, to think about our own implicit bias, to think about the language that we use and how we talk to and about people who use drugs, people who are in recovery, people who are struggling, people who are trying to get their needs met, and to really think about that in terms of language. There are so many trainings available. Dr. Vinsel and a whole team with Kate Chichester at the SUD Learning Community, they are doing Project Echoes. There's an echo starting right now about alcohol use disorder, which we can't forget about, that still takes too many lives in the state of Maine. There's an echo that I'm on the faculty for about injectable buprenorphine. There are so many resources for training that when people hear Dr. Steele talking about 1,000 lives and his bundles, that the resources to achieve these goals are very robust, and there are many in place already. So we have amazing resources. We just need to challenge ourselves by hearing from Dr. Steele about what are these bundles and what was the genesis of 1,000 lives.
Great. Let me give Dr. Steele, who's now with us. Why don't you do a quick sound check, Dr.
Hi there,
Steele?
Gordon. Can you hear me?
Perfect. I'm going to give you a brief introduction, and we've kind of teed this up for you. We've not gone into the specifics of the different segments of how you're going to do this. I also want to acknowledge in the chat that the comment I made about the echo, that Dr. Vinsel, who is another physician champion, is part of that program, along with Fran Jensen, our former Medicaid medical director, who's now with Better Life Partners, and Kate Chichester from the Co-Occurring Collaborative. So I call that to your attention. Dr. Steele and I have had a relationship for probably over 20 years. We're very lucky to have him in Maine. I'm going to give you some of his background, and he can correct any errors, but I think I've got this about right. That Dr. Steele grew up in Massachusetts. He is a graduate of Bowdoin College. He was a journalist in Maine before he went to medical school. That's when I first came upon him. When he was practicing in the Bangor area, he continued some of that journalism and had a weekly column in the Bangor Daily News that was very popular. He was a physician executive with, as well as a practicing physician with what is now Northern Light. He also was a hospital CEO in Blue Hill. He then left us for a bit to become a physician executive in a large system in Ohio. I think it was called SUMA. I might have that right. And then we got him back here, and he's been at Martins Point as a practicing physician for in excess of a year now, and has been treating a lot of people with for their addiction, and during that time became president of the Maine Medical Association, which he's now immediate past president. This project is his brainchild. He's going to tell you about it, why he's doing it, how he and the many partners that I've mentioned are going to do it. And again, we're just really fortunate to have him in Maine and have him leading this effort. So I'm going to give you the rest of the program. You got about 20 minutes to get this done, Dr. Steele, and thank you.
Sounds good. Thanks, Gordon. I don't have any corrections to my biography there. I appreciate you're leaving out the criminal record portions of it. So this, the 1,000 Lives campaign really has come out of both my work as a frontline physician, but also my work as somebody who's really made a career of trying to figure out how to help things get better, and understanding that in order for us to be able to be more effective in our treatment of patients, it can't simply be that you want to do something. You really need the path forward, tools to help you do something. We're all running at about 150% of capacity. And so if we want to improve elements of patient care, people really need support to do that. It's helpful if the ideas are relatively simple, relatively small in number around a specific change, supported by evidence. And the 1,000 Lives campaign came out of a campaign that was run by the Institute, or the idea of it came out of a program implemented or brought forward by the Institute for Healthcare Improvement back in the early 2000s, about 2006, when, as we all know, substantial numbers of American patients die of potentially preventable causes in hospital during the hospitalizations. And the IHI developed a program called the 100,000 Lives Campaign, which was a voluntary effort in which the IHI went to American hospitals and said there are 5 things that if we all could do them, whatever else we might do in trying to improve the care of hospitalized and safety of care of hospitalized patients, if we could all do these 5 things, we think we could save 100,000 lives. And that campaign, again, a voluntary campaign of implementation, was taken up by American hospitals, and well over 3,500 of them signed on to the campaign, and systematically, working at their own pace and with their own challenges, implemented those 5 things over the next couple of years. And indeed, over the 5 years of that campaign, reduced preventable hospital deaths by more than 100,000. And so the 1,000 Lives campaign comes from that sort of basic concept of whatever else we are doing in different parts of the healthcare delivery system, what are the 4 or 5 things that, if we all did them systematically, might reduce the risk of death from opioid use disorder complications among Maine patients, with the goal of trying to reduce the number of those deaths from what's predicted over the next 5 years by 1,000. And so that basic concept, what are the few things that we would do, whatever else we might do, in every emergency department? What are the 4 or 5 things, whatever else we do in primary care, that every primary care practice would do to try to help with this epidemic and reduce the risk of death? What are the 4 or 5 things that every hospital would do, whatever else it might do? And taking that idea of each part of the delivery system having somewhat different roles in the care of these patients, what would be the 4 or 5 things, 3 or 4 things particular to that part of the delivery system? So if you're orthopedic surgeons, and Maine's Society of Orthopedic Surgeons has signed on to this campaign. If you're orthopedic surgeons, you're not providing ongoing OUD care, but what would be the few things that, if every orthopedic surgeon did them, might reduce the risk ultimately of deaths from opioid use disorder? And so they're getting together and, among other things, talking about what are the procedures that they all do that they would agree nobody should get prescribed opioids for, or ideally, if possible, nobody should get opioids for. And what is the best approach in terms of procedures where they might need opioids, but how can we minimize risk to those patients, et cetera? In primary care, the Maine Academy of Family Physicians, the Maine State Nurse Practitioner Association have all signed on to these. The large primary care enterprises of the system, health systems, have all signed on to these. Intermed has signed on. What would be the 4 or 5 things that we would do in primary care? Well, we think it would be educating and reducing stigma, that every primary care practice take care of their own patients with opioid use disorder to the extent of their capability. If they're more complex and they need specialty care, we're not asking to take care of those, but take care of your own. so that emergency departments can have better access to follow-up care, so that patients who are in a trusting relationship with a PCP are more likely to disclose if they have a problem, if you ask them. To take those patients rapidly and transition from emergency departments in hospitals and prisons when they're being handed off after being treated for opioid use disorder, take them rapidly so they don't fall between the cracks between other parts of care and primary care, but get rapid access and then continuity of care for their opioid use disorder. Give them naloxone for those patients, et cetera. So 4 or 5 things in primary care. Same concept in emergency departments, that whatever else they do, every emergency department does a few basic things. Educates staff and reduces stigma, offers induction on buprenorphine to appropriate patients who come into the emergency department with an OUD-related problem and who are not in treatment already. Transition those folks, give them a prescription for buprenorphine going out the door, a bridge prescription to their follow-up care, and get them hooked up with follow-up care, and give them naloxone going out the door, or a prescription for naloxone. So again, that same idea, 4 or 5 things, whatever else you do, every emergency department does those things. We have taken this concept around the state to healthcare organizations, because we believe that it's critical that healthcare organizational leadership support this in order to support frontline caregivers to be able to do what we're suggesting, what we're asking. And we, in the last 6 months, have had sign on to this campaign of the Maine Medical Association, the Maine Osteopathic Association, all of the large systems, Maine Health, Northern Light, Central Maine, Maine General, have all signed on to this. All of the specialty professional associations, with a few exceptions that we haven't finished with, but all the ones that do most of this care, have signed on to this campaign. So psychiatry, anesthesia, family medicine, I forget, the FQHCs have signed on to this. Family medicine, emergency medicine, all of those professional societies, the Nurse Practitioner Association, the State PA Association, have all signed on to this campaign. The organization representing most of the mental health organizations have signed on. So what we've asked the leadership to sign on to is support of implementation of this campaign in their organizations to help support frontline providers and other caregivers to take on this work, because we know they're all overwhelmed and many of them are feeling burnt out. And so you really need that leadership and organizational support to say, we're going to do this. We're going to help you do this. What do you need to help us get there as an organization to provide this care? So that's the basic concept. We have other organizations, that other parts of the healthcare delivery system that we're going to approach. We're going to be talking to pharmacists about trying to work on stigma in pharmacies, making sure naloxone is readily and visibly available in pharmacies. We want to work with the correctional facilities in their care and transition of residents from correctional facilities to the rest of us, et cetera. So more to come on this, but that's the basic concept. So at this point, I would welcome your thoughts, your input, tomatoes, questions, et cetera, and hope that in this conversation, we can get you feeling like this is something that you could help us support.
All right, coming right back, Jeff, just putting something in the responding to something here in the chat. I don't really see too many questions.
Gordon, there
Um,
was a question in the Q&A that I tried to get more information about, and that was about resources available in high schools. And I wasn't sure if they were talking about the social emotional learning curriculum for a prevention measure, or if they were talking about healthcare clinics embedded in high schools and treatment for adolescents with OUD. But maybe you could just comment on
Yeah, I see.
those resources.
I see the question. I can comment on that. There's a lot of course going on between with the Department of Education. There was also legislation that was enacted that requires each school to offer as an extracurricular activity each secondary school at least a training session on naloxone. At the same time, there is embedded in the curriculum in each school, some type of education about substance use disorder. It's generally part of a health curriculum. In addition, there are many opportunities where people have gone in and addressed particular, programs like the work that's being done by the SEED organization, the Students Empowered to End Dependency. So there should be something going on in every school, particularly in every middle school and every high school. There was money that was put into the Maine Prevention Network to have each of the lead partners in those public health districts create a relationship with 3 middle schools as a pilot to make sure that the community organizations were also working with the schools. And a lot of that we focused at the 7th grade level because we have seen use, unfortunately, at younger and younger ages. And we know the data is so compelling regarding the impact of delaying the first use. If you can delay that first use of drugs from age 13 to say age 23, the likelihood of development of a serious substance disorder is greatly reduced. That doesn't surprise any of you, particularly those of you who have way more clinical experience with this than I do. The question has come in about which middle schools are connected to those community partners. We do have that list, Karen, and we'll get that from our partners at the Maine Center for Disease Control and Prevention, and make that available through Lorena can send that out to those of you on the call, and so you'll have that list. And in many cases, it's because it's more than 3 middle schools. The goal is, as the governor stated last January, is to have an evidence-based prevention program in every school. And I think every middle school, every secondary school, that might be like 400 schools, and in every community, because you can't put it all on the school. We also need to absolutely work with organizations such as Tree Street Youth, the Mid-Coast Youth Center, Trekkers over in Rockland, all these youth development and organizations working in that after school and before school space. So, and that's all work also on that's now being supported by the Maine Recovery Council. So hopefully that takes care of some of that question. Positive action teams up in Piscataquis County, we're familiar with that. Governor Mills actually had a role in starting that when she was Attorney General, and the schools have different programs. They have different curriculum. They have different programs, and that's what we would want to have. It's not one size fits all. It's not us coming in and saying this is what you're going to do. There needs to be a good deal of local decision making around, okay, what in this community program would be most effective. Erik, you were going to say something.
Yeah, a couple of things. First, I saw the note from a few of you, Laura. I'd love to see that video if you'd send a link. Maine Health has a good video on stigma education for staff. So does Northern Light, and they've been willing to share. And those are good tools to be able to offer to organizations that would take on the 1,000 Lives Campaign intervention. Gordon's comments are, I think, highlight something about the 1,000 Lives Campaign, that what we're really looking to do is to bring clinicians, caregivers more broadly and systematically into a partnership with state government to help with the things like the school programs Gordon's talking about. So the Maine Academy of Pediatrics has signed on to this and is thinking about what interventions in pediatric practice would be helpful. And so we're trying to think, how do we complement this kind of programmatic approach in schools that Gordon's talking about with pediatricians and other caregivers for adolescents in a way that makes a more effective partnership around this problem. Adolescence is frequently when people develop some of the risk factors for developing opioid dependence. So whether they develop the dependence during adolescence or not, but the PTSD, the untreated ADHD, the anxiety disorders, the family problems that sort of set up that adolescent for then experimenting with substances, a number of them, but opioids, for example. I have 30 plus patients I treat. For the most of them have an underlying disorder that when they first started taking opioids, they discovered that, wow, they actually feel better. And that was for many of them the pathway to their use disorder. And so part of the focus in adolescence about reducing those getting better treatment for those kind of things, preventing some of those kind of things is really critical.
Yeah, I want to answer a question from our friend, I think at the U.S. Attorney's Office, Heather Putnam. She asked about resources available when an adolescent presents to an emergency department with an opioid use disorder or an overdose. We have a ways to go on that, Heather, but I can tell you some positive things. Through the Office of Children and Family Services, there was an entire year or two process to try to get more pediatricians and individuals interested in treating adolescents with substance use disorder. So that ECHO brought in some more providers on the outpatient side. St. Mary's recently developed a process for doing medical withdrawal management for an adolescent. That's the only emergency department in the state that I know that has such a process. And that's obviously not sufficient, but it is at least a start. We now have at least one emergency department that's prepared to work with adolescents in that situation. We do have now the girls and boys beds available for the first time, well, in a while, at day one in Wyndham and New Gloucester for residential care following withdrawal management. So we know we don't have sufficient resources for adolescents, but it's an acute need and we're working on it. I want to come back to the prevention in the middle schools. This is a perfect segue to our program next month, where the Maine Prevention Network on February 2nd at this webinar will be talking about those relationships with the partners in each of those 9 public health districts. And any of you who are interested in what, as the governor constantly asks, what are we doing in prevention? What is going on in the schools? That would be a wonderful hour for you to spend with us as our partners, our very strong partners at the Maine Centers for Disease Control and Prevention. Along with, again, we will have participation throughout the year through our Children's Cabinet with the Department of Education and also OCFS, and their Department of Corrections is involved. And so there's a lot going on in that prevention space and a lot of resources being committed to it. So we're out of time. I want, Elizabeth has clarified her story that she related about Washington County. So I call that to your attention. But I want to just wrap this up by thanking Dr. Fowley Mock and Dr. Steele for giving us their time today. I want to thank all of you for participating in our first monthly webinar. We'll do this, 12 times hopefully this year. And I remind you that we're doing the Governor's Summit. It'll be our 6th annual Opioid Response Summit led by Governor Mills. We're doing it in Auburn at Central Maine Community College. They're very excited about hosting it. We're excited about being there. And it will be in July. I can't be more specific than that. We're talking to a number of potential keynote speakers. We want to set our date around their availability. So more on that. Again, we have a lot to be positive about as we begin the year. In 29 minutes, there's an informational session that the Division of Contract Management is having about the new beds announced for Washington County. There was an informational session this morning on the new project in Kennebec County. The Maine Recovery Council announced beds support in Franklin County and Androscoggin County. Milestone will be opening its new double the number of beds facility in the spring. We've opened up recent beds in Presque Isle, Bangor. There is a lot of positive things going on, along with our more positive experience about immortality, which we mentioned at the beginning of the call. So I encourage you to watch the Governor's State of the State speech, and I hope you'll all be with us. Thank you, Madison and Lorena. Thank you, Elizabeth and Eric. And I hope you all have a great weekend. Stay out of harm's way in the snowstorm. I'm not in Maine presently, so I will be thinking of all of you if you do get a little snow. Have a great weekend.